Good afternoon, everyone. Welcome to the Wednesday afternoon lecture series. I'm Emily Chu, Senior Investigator at the National Eye Institute. On behalf of the NEI and the WSA, I'm thrilled to introduce our guest speaker, our wall speaker today, Dr. Brenda Galley, who has brought a supportive community and an evidence-based care for children with the rare disease of retinoblastoma. Before I do, I want to give you a quick announcement. Hopefully the slides will go back to the CME credit. The code is 57667. I'll repeat that again, 57667. And for those of you who are watching remotely, you can submit questions to the speaker anytime during the lecture and simply click on the button that says Send Live Feedback, which is below your videocast window, and type in your message, and we'll relay that to the speaker at the end of the lecture. And now on to our guest speaker. It's a real pleasure for me to introduce Dr. Brenda Galley, a physician scientist and professor of medical biophysics, molecular genetics, and ophthalmology, all that at the University of Toronto. She also directs the retinoblastoma program at the Hospital for Sick Children, fondly called the Sick Kids. The focus of her research career has been on retinoblastoma, a rare children's eye cancer, and she's been keenly interested in its molecular pathogenesis and clinical impact. In terms of the pathogenesis, her lab has been identifying the somatic inactivation of RB1 gene that can initiate retinoblastoma, pointing to the role of tumor suppressor gene in cancer. They further recognize the pre-malignant precursor retinoblastoma called the retinoma, which is also very important. And they discovered the loss of both RB1 alleles initiates retinoma associated with genomic instability that increases malignant retinoblastoma that develops. They also show that the KIF14 oncogene overexpression corresponds to poor outcome in lung and ovarian cancer, so it goes beyond this. On the clinical side, Dr. Galley's team developed highly sensitive assays and demonstrated the impact of positive, that would be personalized medicine that can be on healthcare costs. That's really helpful. She founded a genetic test lab called the Impact Genetics to provide the highest sensitivity mutation tests for families all around the world, which empowered her to lead an international team in 2013 discovered an unrecognized form of retinoblastoma without the RB1 mutation itself. So this is just really a smattering of her extraordinary 50-year career. Today you'll hear more about data science that drives her team discovery. She has received many, many honors and accolades. They include Lifetime Achievement Award from the Canadian Ophthalmological Society, the Helen Keller Prize for Vision Research, and both an Order of Ontario as well as the Order of Canada for delivering personalized medicine. And she certainly has mentored a number of general ophthalmologists and researchers, and she was one of my mentors. She actually got me into ophthalmology when she told me that you should be doing this instead of something else, and here I am. Thank you very much, Brenda. The title of Dr. Brenda Galley's lecture today is Rare Retinoblastoma Contributed Over 50 Years of Understanding Cancer. Now, can we now reach every child? And I hope that the answer is yes. Thank you, Brenda, please.
Thank you very much, Emily. Emily understates her contribution to my work, but it's really, she's had a tremendous influence on me. So thank you for inviting me here. I thank the NIH director, who I'm sorry is too busy today, and I understand that, but I'm really honored to be here today. All the symbols across the bottom are charities that supported the work in different ways, and I think there's probably a few I've not got on there. And at the top are the three institutions that I work in Sick Kids, UHN, University of Toronto, but IRBC is a charity you'll hear much more about, and it's really pushing forward to reach every child. So I can just do this. Some wise person told me I should say the 5 points of what you're going to hear and what to learn, so we'll go quickly through. Cancer is a genetic disease. Lack of prospective data delayed 30 years the recognition of very serious harm from a care I was responsible for giving to patients. Retinoblastoma is still the only cancer to include genetic predisposition as a risk factor in this world staging system. And early term delivery of these babies, now labeled H1, carrying the genetic predisposition, optimizes vision and minimizes therapy. And sustained release of the chemoplaque delivers drug only to the eye, and that led to the first and only clinical trial I've ever had anything to do with it, a phase 1 study. and with 3 different new concepts in clinical trials there, a definition of complete response, consequence score, and propensity matching. And Depict Health is looking forward to the whole world. It's point-of-care data, consented propensity to evaluate interventions, and full view for life for the patients with retinoblastoma to be able to see for their whole life long, anywhere they are, everything that's happened to them with respect to retinoblastoma, particularly looking for their subsequent cancers. So I started in retinoblastoma, and all the fellows I had a wonderful lunch with know all about this. I was a third-year resident in ophthalmology at Sick Kids, called to emerge in 1973 with a recent immigrant who came in with a diagnosis of cataract on his immigration file and had red eye, and you can see the picture on the left shows tumor in front of his iris, and that eye was enucleated, and this is his blue cells of his tumor growing down the optic nerve. So he had metastatic tumor all over. He was sadly treated with external beam radiation and horrible chemotherapy because in 1973, our obligation as clinicians was to save life. We couldn't think beyond that. We had to save life. And he died a year later when he should have been dying peacefully at home with proper palliation, which would happen today, I think. So we have built a database, which I'll come back to, but I'm showing it here because called eCancer Care RB, that runs in Sick Kids, and every time we do an EUA or see a kid with retinoblastoma, we enter data directly into this database. And so I retrospectively found his real chart when I had to move out of our offices. And there at the bottom of my filing cabinet was the real chart. And you can see this is a slide. The young people won't even know what a slide is, but that's a piece of film mounted in cardboard. And I wrote December 73 on it. And this is the database I entered the data from his chart into eCancer Care, showing you that the yellow triangle means enucleation, and the orange rounded square is external beam radiation. I'll use that throughout all, and I might ask you, what have we done with that eye? And you'll be able to tell me by following those symbols. So in 1973, I was instructed to present this case of retinoblastoma to citywide rounds. And I went to the hospital library, and I found Al Knutson's newly published paper, 1971, showing to me his mathematical analysis showing this was an exponential curve for bilateral, so only one event caused the retinoblastoma in children with bilateral disease, whereas the unilateral, who didn't necessarily have risk for their children to have retinoblastoma, was a more complicated curve. He called this a 2-hit curve and this a 1-hit curve. In reanalyzing even his own data, we think this is more like a 3-hit, but that's a minor point. And that showed to me that cancer is a genetic disease, and now we all know that it controls cell division and genomic stability, et cetera, and that the RB1 mutation, this is my work, subsequently contributed a lot to detection to offer precise care for families with retinoblastoma. So going back still into history to important things, in 1969 and 1982, the New York group, who were the center of retinoblastoma patient care at that time, and that's why I did my fellowship in New York, because I wanted to pursue retinoblastoma. And they wrote in those papers, radiotherapy, the most valuable weapon against retinoblastoma, and that the mainstay of treatment is external beam radiotherapy. And that was quite a few years, 30 years more, before the brilliant scientists here at NIH showed that they needed to really look at data, and they looked at data, retrospective data collected in Boston and New York, lots of patients, and showed that those that were H1 had a 50%, greater than 50% risk of a subsequent malignant neoplasm by age 50. That had not been recognized because no data was collected between there and now until they retrospectively went back to here. And if the same patients who were H1 carried the RB1 mutation, didn't have external beam radiation. They still had a high risk of subsequent malignant neoplasms, but nothing like the impact of radiation. So jump ahead now to 2017, the Cancer Staging Manual that was revised in that year for all cancers came out in a big book that's about this thick for the cancer staging of every cancer. But the only cancer in that book that mentions genetics having an impact on prognosis is retinoblastoma. And this data that went into the new way to assign the level of disease in the eye is based on data I'd collected over 2001 to 2011, and analyzing that data said that the previous ways to stage cancer, starting with Reese-Ellsworth classification and the other ABCD classifications, weren't as good as looking at the data that came out of here, and that's the cancer staging TNM. That's what I'll show you more of. And that work has all been really supported in that clinical database collection, that clinical survey, by the Eye Cancer Foundation, led by Paul Fringer in New York, who is an actually brilliant, tireless, dedicated person to world retinoblastoma, world eye cancer. And so this is the H1 status. That chapter in the 8th edition of TNM is now TNM-H for retinoblastoma. H means you don't know, no evidence of a constitutional RB1 mutation. H1, it means bilateral, trilateral, or family history, or an RB1 pathogenic allele identified in studying the genome of that patient. H0 is only applied when you know the relative's mutation and you prove that the baby in front of you does not carry that relative's mutation. But if I tested a unilateral who might be either one, as Knudsen showed, and we don't find any mutation in the genetic testing, we call that H0 asterisk because the testing can't go below 1% mosaicism. But if that patient was mosaic at 1%, their babies in the future would have bilateral retinoblastoma because they would have been descended from one of those mosaic sperm or ovum that carried the RB1 mutation. So that's why the asterisks on some of them. So jump back to family history. I've cared for not the grandmother, but you all know that the grandmother in 1949 had both eyes enucleated, right? You can tell there's yellow triangles for her. She's alive and well. I talk to her regularly. She's worked for Revenue Canada all her life. She had 4 children. I didn't care for the first one because I was too young at that time. But all of those, that child was bilaterally enucleated. But all the rest of her children were treated by me, managing their retinoblastoma with external beam radiation, the square there. And we did that because we knew, as Ellsworth and Abramson pointed out in their papers, we could save vision and save eyes. We had no idea what we were doing to them in second cancer risks. And you can see the grandmother's alive and well, but her 2 oldest children have already died of their second cancers. And these 2 remaining do not have their second cancer diagnosed yet and are very concerned about that because here's the 3rd generation now. The first child looking for the precise H1 mutation in each pregnancy. The first and the 3rd are H0 because we know we can be precise. They don't need an asterisk. But the middle one is H1. And now you can see, because we know of that child, just going back to the radiation risk, sorry. Now in Canada, all H1 babies are delivered at 36 weeks, which is early term. That's only in Canada. That's not happening in the States unless a family that we've managed, and they know about this, demanded. And I know of one that's been managed in Boston with early delivery because they said we must have early delivery to look at our baby's eyes. And this is a picture, for example, of a 36-week-year-old. Here's the optic nerve right there. Here is these little arrows point to where the tumor is identified, but on the looking with the indirect ophthalmoscope, you can't see it at all. Looking with the camera, you can't see it at all, but the OCT sees it. Can you see that tiny little circle there in the internuclear layer? That's where retinoblastoma emerges. And then we don't know where that is, so we follow the blood vessels out here from the nerve, and we say we think it's there, and we put in a laser burn. And then we do another OCT immediately, and we can see that now the tumor is that little round thing there, and here, going right back to the RPE, is the full showing that laser burn. So we've hit it correctly. But now we see a spot on the retina. Now we can continue treating that because we can see it with the when we're using the laser. And then we keep treating it until we've got it thoroughly evaluated that way. This is then on this child, for example, we did all that laser, and this is a laser-treated tumor in her eye, out somewhere near the periphery, but with a really good OCT showing our lasers caused a problem. That's a vitreous seed. Vitreous seeds, it's a very good picture of one because they're hollow in the center. All the nutrition for that clump of cells comes through the vitreous so that the cells in the center die, and you have a rim of 10-cell thick wall, which you see right there on this OCT. So if we continued to use focal therapy, laser or cryo, we could have had an eye full of vitreous seeds at that point. So then we needed something else to do, and what we did was the chemoplaque, and I'll show you more about that. This is after the chemoplaque later, and now that we can keep following that, and there's been no more recurrence, no seeds further. So we the eCancer Care database I showed you on my patient 1, loaded retrospectively, but we use this only inside sick kids. It's a beautiful program made by the developers at Princess Margaret Hospital that I've talked more about over lunch that still work on exactly this. But that is a prospective. Data is entered in the OR every time we see a patient, or in the clinic every time we see a patient, and it's at the point of care, and it's a repository of the data. So in eCancer Care, the prospective part is from 2001 to 25. We're still using it today in sick kids, but it's old. It's going to die. The server's going to die because it's on old software, old technology, and so we really back it up regularly because we don't know when it's going to fail. We put that database into Kenya, where the ophthalmologists loved it, used it, but would phone us to say it's not working. We'd find out there was a power failure, the server wasn't turned on, and we realized we can't go globally that way. eCancer Care can't do that. So we built a whole new model called Depict Health, and this is its byline is Full View for Life, you'll see, and it's prospective point-of-care repository of data. And this is the charity that runs this. The charity pays the University Health Network every year for exclusive license to use my database that is owned by the Princess Margaret Cancer Center. This is Depict Health, what it looks like. This is a beautiful tool to use. If you clicked, and I could do a demo after if you want, because we've now got this running live, but I haven't time to do that now. And anytime you point to any of these, when it shows the date, you double-click and it opens the whole event, and you can see everything. You can see here's the AJC-TNM staging for this particular child. This is the staging of the eye, no nodes, no metastasis, and H1, because it's bilateral disease. And the right eye is and both eyes are CT2B. But the lines that cross both eyes are systemic, so that's the genetic testing is green, and all the blue lines are systemic chemotherapy. These triangles up there are intraarterial chemotherapy, only to this eye. And what did we do with the left eye? We enucleated, you can see right there, after all this chemotherapy, because it was threatening the optic nerve. And then we did more chemo, and we were not winning here. So I went to a World Congress, sat in Lisbon having coffee with Lynn Murphy, who was my equivalent colleague in retinoblastoma at Children's LA. And he said, that little device I've been working on to get drug only into the eye without it being absorbed in the whole systemic circulation has been approved by FDA to put in a human. And I said, I have the patient that needs it. I went back to Toronto. This patient, we were chasing all these little tiny tumors, all emerging from this primary. And then he had got a retinal detachment recently, blue is retinal detachment, and it obviously affected his vision. And all these drawings are done in eCancer Care with beautiful tools. It's really, really quite fun to do them. And you upload to Depict Health key images that support the story for that event, but not all the images. Oh, by the way, all the data that is coming from going into Depict Health isn't custodian of that data. It's a communication server across the whole circle of care. And the site, Sick Kids or whatever the site is still remains custodian of the data. So our choices for this child were enucleate his last eye or do EBRT, and he has a nearly 20/20 vision fovea. And so what we did was spend a week with Health Canada getting special access authorization to put this chemoplaque in this child's eye, the first human in the world to ever have a chemoplaque. This is the chemoplaque invented by the ideas of Lynn Murphy and Ricardo Carvalho, who's now in Brazil, and David Carpy runs the company that produces this. The yellow is topotecan drug in a solid form that will diffuse into the eye. This is the nice little holder, and all the people who had lunch with me have felt it in their hand, and you're welcome after my talk to feel it. Sorry? How big is it? About as big as your baby fingernail. I'll show it to you. Yeah, very small. And this is putting crazy glue with blue dye. We have to call it tissue adhesive because it spends a lot of money by putting the blue dye in it, but it's crazy glue into that little groove right there. You mustn't put any over top of the drug or it won't do the job. So we left his in 70 days because it didn't seem to be causing any problem at all. And when we looked in between, and the tumors were getting smaller and smaller, and when we took it out, the only active tumor is still here where his primary tumor was, near the calcification. And all the rest had disappeared completely. And ultimately, we took out this tumor with another new procedure that's been promoted and done with my colleague John Chow in China, and that's just do a vitrectomy and take out the active tumor. We have trouble publishing that because top editors for ophthalmology journals say you can't open up an eye with retinoblastoma, you'll kill the kid. But the data from that, which is widely published now from Chow and many other collaborators on the paper, show that by taking out that now tumor that has failed many treatments and therefore become more and more genomically resistant, that it actually saves lives and saves eyes. It's better than leaving genomically progressive mutating tumor in the eye while you try to treat it. So this kid is now 4 years out with 20/40 vision. So Health Canada said you can only do 3 of those. 2 of them weren't as well selected as he was. And then you have to do a clinical trial. I've never done a clinical trial in my life before this one, but with the help of 3T Ophthalmics, the company that is managing and building the chemoplaques, and Phoenix Children joined our study, and that now is covered, is constant. So Dr. Aparna Ramasubramania and all my team at Sick Kids are here for this study. And we did this as a phase 1 study, and this is the design, 3 escalating doses. There are 2 plaques, there's 2 designed, one with 0.6 and one with 0.9, and the one I can show you is a 0.9, which I like best of all of them. And then escalating doses, but the higher doses require placement of 2 chemoplaques. They stay in for 6 weeks and then take it out, 42 days. We picked that because at 50 days in the rabbits, there was no drug really left. And so we went to less than that so that the participants in the study would have a more constant dose level at 6 weeks. And then we monitored them officially in the study for 9 weeks with 3 years follow-up. And this just shows the chemoplaque and how you put it between rectus muscles. Preferably, we put it inferiorly in either quadrant because it does cause a footprint scar, and we'd rather those be making a superior scotoma than an inferior scotoma affecting life skills. So this is a special kind of swimmer plot, swimmer RB, which I'll reuse many times through the rest of my talk. And this was actually invented by an undergraduate summer student who loved Excel and was pretty smart. And she built this way to take our data from our eCancer Care database and display it with the only data is what's the treatment and the treatment and the date it was delivered. And that comes from our prospective database. And so that data goes into this swimmer plot, and this is the doses of the drugs. So you can see the blue down here is the 6 milligram, et cetera, and up to the higher doses. Then we invented another thing, because cancer staging, and to say your treatment, your therapy, whatever it is working, you have to have some measurements that are standard for the cancer. And for retinoblastoma, that's really, really hard because of all those little pieces of tumor all over the place. How can you know what to measure? So we said, let's get really simple and follow along our swimmer plots and say complete response. It means after the intervention, you don't do anything else. There's no other anti-cancer treatment to the patient or the eye. And that's what we show here. And dose-limiting toxicity scored there. Now this database is more expanded, so it automatically puts in the CRs and does all those extra things, so I don't have to fill them in on the PowerPoint anymore. And now we have achieved the recommended phase 2 dose. I'll show you the data behind that, but you can see there's a lot of CRs here, a lot more than in the smaller doses or the higher doses, and a lot more DLTs at those higher doses, which is why we arrive at the recommended phase 2 dose of the 0.9 and 1.2. So here's another approach to this. We thought we would have to design a randomized trial to get FDA to let us go forward. But then we realized buried in our eCancer Care database, displayed on a swimmer plot where we put here diagnosis and week 0 is the date of diagnosis of that patient. Then we can display all the treatments that those eyes received. This is eye-based. And here is the retrospective view of that of cancer treatment for retinoblastoma. Before 2010, and much longer before that, but we're only showing that here, it was mainly external beam radiation. And if we went lower than that, it would have been 100%, but I don't have that data easily available. And then Dr. Helen Chan, who's a crazy kind of enthusiastic, energetic chemotherapy, pediatric chemotherapy oncologist, she developed chemotherapy for retinoblastoma, and that was considered heresy by the external beam world to actually try to treat retinoblastoma with systemic chemotherapy. And more recently, intraarterial chemoptherapy, thinking you'll give it only to the eye through the the interventional radiologists put it into the ophthalmic artery or near the artery. And that's dominating the world right now as the best care for intraocular retinoblastoma. Chemotherapy still is a basic standby for all of these throughout this time now. Systemic chemotherapy. In a bilaterally affected child that needs chemotherapy for both eyes, we in Toronto would always go to first systemic chemotherapy, not bilateral intraarterial, which has lots of risks to the eye and the patient. So here's the results showing why we call these 2 doses the recommended phase 2 dose, and combining those together at 77% complete response rate. And that sustained complete response as long as we followed the patient. So here is the retrospective controls treated with intraarterial chemotherapy in an equivalent time window to when the chemoplaque patients had their treatments and diagnosis. And you can see with 3 and 4 cycles of IAC, that's the best complete response rate compared to 77% for the chemoplaque, which is sustained release. And that makes sense. As soon as you give a pulse by systemic or intraarterial, you kill lots of the cells, the thing gets smaller, but the cells that have survived have acquired new genomic changes and become more and more resistant the more you give them a pulse. But the sustained delivery of topotecan into the whole eye doesn't give them any window. They never can escape. That's, I think, part of the answer. And then we looked at this by chance and said, well, if we count back on our swimmer plot, you can see how many eyes were enucleated. And we were quite surprised that 2 eyes had been enucleated for any reason. It would score on the swimmer plot as an enucleation yellow triangle. And there were 2 from the chemoplaque patients, and there were many more from the IAC. So now we want to do retrospective proper comparison to the e-cancer care patients in this retrospective window compared to the 0.9 and 1.2 chemoplaque study. Here in the chemoplaque study, we had 22 eyes, but we can't score for this match if they had no other treatment, or if they were a lot older. So the study eyes for matching were 18, and then we went through a path starting with 97 eyes and working our way down to ones that could reasonably match, gone down to control eye of 45. And we thought we should be randomizing one of these eyes to one of these, but I learned last night from that's not the case. We should have as many of these as possible. So this will be revised soon. And this is another Canadian refugee. We have great refugees in Canada. And Kelvin is an engineer with a master's degree from Hong Kong, fled to Canada when China took over Hong Kong. We hired him when he was washing dishes somewhere and hired him as a research assistant. He's absolutely brilliant, and he's done all this work on all of this and making the swimmer plot better, and he's very much a key person to this whole study. So the propensity match is matching the patients across here, and the plan is to calculate the consequence score for each eye. You don't know, you haven't heard about consequence scores, have you? The consequence score we just invented out of our heads and said it's arbitrary, but it's intended to estimate the perceived relative harmful side effects of any of these treatments. And you can see the ones that hit the top are EBRT and enucleation of a last eye. And we just gave those a number of 30. And focal therapy has only, that would be one treatment of focal, not counting the number of burns in the eye, but just that episode that scores on the swimmer plot. And that's what we decided we would use. It doesn't matter what the real numbers are, because in all the future calculations, the numbers are the same on both sides. It just lets us quantitate outcomes and events and propensity matching. So here we have the chemoplaque, and we count the consequence score by 3 intraarterials. Each one counts 3, so that gives a total of 12 would be the total consequence score before a chemoplaque was placed in that study patient, sick kids 25. And then we look through all our retrospective controls, and we find others that have a consequence score of 12, and then we would pick the week 0 to be the date of the next treatment that they might have gotten a chemoplaque but didn't. Does that make sense? I hope so. So that gives us a whole set that are matched by that criteria. And then we also improve the match by looking at the treatment pattern. So you can see here our chemoplaque patient had 4 cycles of intraarterial, but this patient has a consequence score also of 12, but had only 3 intraarterial and 3 lasers. So that would fit if we're matching only by tumor pattern. But this one fits better because these are intraarterial that match the 4 intraarterial there. And at the moment, we've said we'll do a randomized selection between these, but I learned last night that we should just use both of them going forward because we want to enrich the numbers in our retrospective controls. So here we are looking at the RP2D for perfectly one-to-one matches between the chemoplaque and the retrospective controls. And here we've set propensity matching, as I just described, plus other things like staging of disease and right or left eye and genetic status and everything are matched between the groups and don't have any difference between them. And the propensity matched at week 0. Here's the insertion of the chemoplaques. So if you look at a Kaplan-Meier of this result, the matched retrospective controls versus the chemoplaque, and that shows a very significant value to the chemoplaque compared to these matched controls. I'll show you one beautiful little patient. This is step RB 15, and this child should have been diagnosed at week 30, gestational week 36, as you all know now. That's what we do commonly in Canada, and but got missed because investigating the family and things was passing back and forth between genetic labs and families and this and that, and the testing, the genetics was delayed, and no one recognized that her cousin, both had this, their fathers were identical twins, who actually had never had retinoblastoma, and so this child already had this central tumor at that point in time. And here is the only picture I have like this, but it's an ultrasound, obviously done right across there because it shows tumor and it shows the chemoplaque on an ultrasound. That's the only picture I have like that. So you can see how it's glued with its crazy glue at the front of the eye here, and it's happened to kept it in profile there. This is at week 9, at the end of the toxicity, and it shows the major toxicity. This green dotted circle is the footprint of the chemoplaque, and it always causes a little bit of scleritis, sometimes more vitritis than this, and hemorrhage, and ultimately the retina is destroyed. But at this week 9 picture, the OCT shows that still active tumor sitting right there on top of the calcium. But we just kept following that. We did not do any interventional treatment. And by week 35 and now out to 3.3 years follow-up, it looks just like this. This is the scar causing that scotoma, which will be in her superior field. And they all have this outcome from the chemoplaque footprint. And now there's no more tumor anywhere there. And her timeline is chemoplaque and no other treatment. So she's still in complete response at 3.3 years. And this timeline and this method for CR leaves not much room for discussion around it. Actually, if I go back here to this, here is a little drop down way out over here at 90-something weeks. That was one patient, one participant in the study who showed a hot spot on fluorescein on his soft part of his regressed tumor, and we lasered it because the whole team makes the decision that that's the safest thing to do for his eye, even though it might not have been tumor. We only did one laser treatment, and that drops this down on the Kaplan-Meier by 1 point because he no longer is a complete response because we treated him. But that's no problem. We put patient care first in this way. So now we're out here, and here's this little girl who taught us something that we did not think about before. Eva, I can use this, and that's her picture. She's very proud of being in my talk. And her vision measures very poorly because her central vision is right there. She's not going to ever have good vision out of this eye. But she's patched to force her better eye is patched so that she will optimize the vision of this eye. But wise people, ophthalmologists, said, why are you bothering to patch? There's no possibility it ever change her central vision. And they're right. But she runs around with her patch and plays with balls and catches things. But that's because she's using all the rest of this retina. So we've said, patch forever at some intervals, not routinely, but keep patching maybe for the rest of your life because you don't want to lose the function of all this beautiful retina that she can use to do a lot of things in life. So in retinoblastoma patient care, we've never paid attention to the visual field. That's a new study. Please come and start this study and follow the visual field of all these patients with scars all over the place from infancy and find out how that correlates, those visual field changes correlate with their job prospects and what they like to do in the world. And it will be very important in follow-up for the families. So you can see I've used data in many ways. I'll just point out that this data here, this data from New York and Boston, I commented on, and that eventually led to the recognition that EBRT was not a good thing to do to H1 patients. The retrospective repository that I I built from 2001 to 13 at the University Health Network that fed into the cancer staging. It's now the AJC cancer staging, including H1. And there's another even older registry from the Netherlands that they pulled out fantastic data out of. So having really retrospective repositories is very, very useful. The Chinese group work with many patients, joining 28 centers together, but all the patients in one database. And I've had the privilege to work with Dr. Chow in China, and now a medical student who originally was born in China, but is now a resident in Ottawa, in Canada, and he works through this data with the three of us, writing all sorts of papers out of this repository that show, for example, that the safest way to save a child's life is to enucleate. Primary enucleation is a really good treatment, particularly for the whole world. This is our prospective e-cancer care database I've talked about lots of, and I'll come back to that again. So to depict health worldwide, we need to know how to reach centers worldwide. Helen Damaris, who did her PhD and is the one who really showed the molecular changes in retinoma from active retinoblastoma, the genes that drive the RB1 minus cell to become more and more aggressive. She also has now built a tumor bank for the world, all based in sick kids. And she did many years ago set up this map. You can go to that URL and jump right into this map. And any time you point to a green spot, it will tell you pretty up to date how many patients are seen there, what kind of treatment of tumors do they have available in that site, and who are the active oncologists and ophthalmologists and anyone involved in the care in those sites. So this map, and we know most of these people, not all of them, of course, but we know lots of them, and those are how we'll be able to expedite moving Depict Health to the world. So this is Depict Health, which anchors the circle of care. That's its primary role. Here is the circle of care, and all the blue circle, which includes patient, family doctor, pediatrician, etc. They can view all the data, but all the people in the blue circle here are the clinicians of all different descriptions and survivorship specialists, nurses, everybody who would enter data into Depict Health. The data, they don't take, this is not in the EMR of the hospital site. It's filled out by the clinicians of all different types, but it's very simple, very easy, and it becomes a communication service across this circle of care. They put in the accurate data, but the auditors to say, did they make a mistake, are the patients and the parents, because they can watch this. They can be in the waiting room ready for us when they, while we're actually working and putting the data into Depict Health in the OR. So the patients participate with a communication consent signed by them to the hospital that is the custodian of the data, for example, Alberta Health or Sick Kids, and they have to have one communication sent with each of those institutions. And then if the patient's parents sign an optional research consent, then coded and aggregate data can be delivered back to each site so that in a research-ready format. We don't steal their data from them. They can do their own research and pass that. That goes back to the site. And so we help them to do their own research. But we also take that data from there and take it through Global Reach and other means, but the one that is right now really functional is this Pediatric Data Commons, Pediatric Cancer Data Commons, built by a fantastic group in Chicago, and they did not have any commons for retinoblastoma. They had all the other pediatric cancers here with great names, and they said, we want to add retinoblastoma. And so they came to us. They'd heard about Depict Health, and we gave them the whole database so that the data in the data commons for retinoblastoma is matched up really well to the data in Depict Health. And that can go to REB-approved research, but I don't have to judge. We in Depict Health don't have to judge who's allowed to have that data. The Pediatric Data Commons have all those processes in place, which is really, really nice. But the other thing about this is that data couldn't produce and support national guidelines because the data is specific to whatever sites are involved. And that can reflect regional realities. And in that way, patients become also advocates to help other patients. So it goes really full circle around. And as I've showed you, the power of this longitudinal data going forward here also can be used as a propensity match out of Depict Health. So you can imagine, as this is really site-specific, you could tool which data are you going to look at to match to which patients in which location for which kind of circumstances. And that's very exciting thing arising out of our first, my only clinical trial. So jump to this patient. You may recognize him because all I've done here is take his Depict Health timeline, and I entered March 2036. So that squished his whole timeline down. Here's all his systemic things. Here's his left eye still shows as being enucleated, and here's his little chemo plaque right there. And now he's about here with 4 years and 20/40 vision, but he has a whole life to lead. He hasn't had any external beam radiation. He has had other things done to his eye. So now we can use Depict Health will become to follow a way to follow his second malignant neoplasms. We really hope out of cell-free DNA studies led for the eye by Jesse Berry, my wonderful colleague who took over from Lynn Murphy in LA, for ultimately to develop blood tests that will see cell-free DNA circulating in the blood that will come from any dying cancer anywhere, not retinoblastoma, but any cancer. And that cancer signal, so far we put a grant in, we didn't get it because our patients at risk are too rare. But for Li-Fraumeni syndrome, they've got data to say that this can predict cancer before it's otherwise evident. So these S's mean that this is a surveillance test that will be ordered by a simple blood test on some regular interval based on the data. We're going to resubmit this now with the power of the patients who are really eager to know when they're going to have a second cancer. So that's my talk. I would love to hear if there are questions and suggestions that can make our work better. Thank you. Online, are there any?
Thanks. Caught me a little bit off guard there. So we welcome questions at the mics, of course. I do have a few to get started. This one, just so you know, it came early on, so you kind of alluded to it. When does tumor formation and vision deterioration start? In utero? And how soon can the chemoplaque therapy start? Is time of the essence, or is there an open window for therapy to achieve significant positive outcomes?
That's a very, very good question, comment. We at 36 weeks gestation, 30% will already have a tumor detectable by intense OCT screening. So some younger than that before we are ready to deliver them. And some of those in the study we first published on this actually were born earlier than that because they chose to be born for other reasons. And but that's about the time window. So if you look at the beautiful work by David Kobrenick in LA on most models of how retinoblastoma forms in the cone photoreceptor precursors, and that's quite fascinating. How early do they start? But I think by screening at 36 weeks, that's a good time. We do that routinely across Canada, but the U.S. doesn't do that because the obstetricians say if I deliver an early-term baby electively, I might be sued. Right. And that's a problem because if they're born at 40 weeks, they could already have a big tumor. There's other ways that have been done to try and find tumors when they're in utero. We did ultrasound and found one and published that, but that one, we never found another by obstetrical ultrasound. It's a very difficult job. Lynn Murphy did an MRI study on pregnant people to see if he could find them that way. Again, it was did not yield any useful data. So I think it's better to deliver them at 36 weeks and see what you've got. And then we have got, in our most recent design of the next study, we have got a 0.3 dose chemoplaque available, which was manufactured and tested in rabbits, but we've never used. But that, we would put that on a baby that had a larger tumor, not one you could laser, not one that would be appropriate for focal, but we could put a chemoplaque on a tiny baby that had a macular tumor or something. Even a macular tumor you didn't want to laser because it would damage vision. That would be great for a 0.3, but it hasn't been done.
Dr. Brooks?
Brenda, it was a great talk. I'm wondering what your planned control group is for your upcoming phase 3 trial on the chemoplaque.
Our control is retrospective.
It's going to the FDA will allow retrospective in this case?
Well, this study was taken to the FDA, and we had in our back pocket, we had already designed with 3T ophthalmics a randomized study. I said you could never do that in retinoblastoma, but I thought it was kind of nice because it had a crossover if there was either side, and that sort of made it all right ethically, I thought. But as they walked in the door, they said that retrospective controls are so good, it would be immoral for us to ask for a randomized study.
That's very comforting. Thank you.
And that apparently this isn't the only precedent at the FDA. This new logic has penetrated in some other disease. So that's really refreshing. So our planned phase 3, and now I learned last night we don't need to do a phase 2 because our data is so good. We can go straight to a phase 3, which is really exciting. I've never done clinical trials before. I don't know what a phase 3 means, but I'm going to have to learn soon, or somebody does. I don't need to do everything this myself. But that will be using in Depict Health. If I jump back here, you can't see it. Can they see my slides if I go backwards? The propensity data for every patient will come from that site, from all their patients that did not be perfectly matched, just like I showed you, for patients that did not get a chemoplaque.
Yeah, that's great. Thank you.
Thank you.
Okay, another one. You might have been expecting this. Amazing work. Can you speak more of the consequence score? What factors go into the estimate? Is this more of an intuition or a set of checklist checks?
The consequence score was made up by me. Those numbers I said, well, we've got to make the worst EBRT, and it's the standard for failure in the ophthalmology literature for retinoblastoma patient. Failure is EBRT or removal of the last eye. That's in the literature everywhere. So I just stuck 30 on it, and I said focal is the least we can do. We've actually added EUA because EUAs have consequences too, but we gave it a 0.5, I think. And then we did design a little study to try and say, are these numbers the right guesses? But it doesn't matter the way we're using it because they're on both sides. They match everything. It's the same numbers. It just quantitates impact on that swimmer plot instead of just saying, counting how many events happened, which are a very different impact comparing a nucleation of a last eye versus laser. That's all it is. But I don't know of any other disease or cancer that's used that concept of consequence score.
But this is my own question. It seems applicable, no?
Sorry?
It could be applicable to other cancers.
Absolutely.
Right.
And maybe it could be applicable to AMD. And I would love to hear more from Emily about all these things because, the chemoplaque is sustained release. There's lots of ways, and in our fantastic lunch I had with all the fellows and students, there's lots of drugs you guys are inventing here, or discovering and working on for the eye, this beautiful organ, the eye, that teaches us so much about the whole body, that the consequence score could be a relevant thing to evaluate outcomes, yes. But retinoblastoma invented consequence
So
score.
noted and archived, so we got this down.
Why is external beam radiation such a risk factor for subsequent malignant neoplasms?
Because radiation induces cancer predisposition changes in the genome of any tissues, And yes, a lot of the really nasty tumors are in the radiation field of the eye that was irradiated. But when you go into the radiation suite where they're delivering external beam radiation, you wear a zillion layers of protection for you because there's radiation everywhere. And that's what the data, I don't know of any science proving that, but the most common cancers are melanoma, and for women, the hidden cancer till very recently, when they really looked at data, is ovarian carcinoma. And that was a really nasty one because several of my patients have died of their uterine cancer, cancer, and because it gets masked as and called fibroids, and no one would pay attention to it.
Thank you.
So that's why the risk is there. It's inherent in carrying an RB1 damaged gene.
Okay, perhaps one more question online. Thank you for a wonderful talk. Perhaps not entirely relevant, but can you share anything about the Canadian health insurance landscape? The therapy doesn't seem extremely expensive. Are these procedures covered, or is charitable support needed?
The Canadian healthcare system still covers the basic care for, none of these are charged to the patient. The chemoplaque so far is research. We don't know the price of the chemoplaque once it gets that far and gets allowed to be sold. I don't think it compared to the costs of interventional radiology in an interventional suite with all of these different things is pretty less. Mm-hmm. So I think it's a really good thing for global retinoblastoma, because if you put it in Africa and the patient disappears, which often happens, you don't need to worry. They just have this little silicone thing in their eye forever. It doesn't make any difference, that kind of thing about it, yes. But cost is not an issue in Canada. I'm sorry, I can't speak to the U.S. It's very, very different here.
Thank you very much, Brenda, for a wonderful talk and all your discussion, and thank you all for being here. We really look forward to your next trial to see what happens for these little children. And I think it's heartwarming that you're doing this for globally around the world, that people are getting benefits from your research, which is fantastic. Welcome all of you for a reception outside after this, and thank you very much for attending, and thank you for all those questions from online. Thank you very much, and thank you for being here, Brenda. Really appreciate it.